Hi, good evening. My name is Chloe Yuli, and today is February 7th, and today we'll be talking about the overview of hypothyroid disease. And this is study number 59. In the initial presentation, she was a white female who was 8 months pregnant at the onset of her illness. She's 5 feet 2 inches tall and she weighs 140 pounds. She has a son and a daughter from a previous marriage, and she has also suffered one miscarriage previously. When she called her primary care doctor's office complaining of severely sore throat, a temperature of 102 Fahrenheit, she had a mild uterine contraction and she was told to go to the ER immediately. And the ER doctor chose to hospitalize her and treat her with antibiotics and IV magnesium sulfate to stop the contractions. 4 weeks later, after the uncomplicated delivery, she gave birth to a healthy female child. And approximately 6 weeks later, she saw her primary care physicians with multiple clinical manifestations. She was complaining of being tired and weak, joint and muscle pain, constantly feeling cold. She gained about 30 pounds since her last delivery. She had recurrent headaches, mild constipation, a lack of menstrual period, and she also took ibuprofen that didn't help her at all, and also mentioned that she was having difficulty hearing and comprehending, which often felt closed off in another world, oblivious to what was going on around her. From the clinical course in the history of presented illness, the primary care physician noted that her speech was very slow and deliberate. Her voice was hoarse, hands were swollen, and her face was puffy. Her skin was extremely dry and flaky. Her heart rate was 46 beats per minute. There was no thyroid megaly, and they noticed that she had a poor mental state, and the primary care physician instructed her that she could not drive anymore because her alertness was gone and her reaction time was slow. So let's discuss hypothyroidism. This is a result from deficient production of thyroid hormone by the thyroid gland. When this is left untreated, the hypothyroidism increases morbidity and mortality, where generally the individual lacks iodine in their diet. The leading cause is an autoimmune thyroid disease, but other common causes include drugs such as amiodarone, thalidomide, oral tyrosine kinase inhibitors such as sunitinib, imatinib, other drugs such as rifampin, phenobarbital, phenytoin, and lithium, and so on. Other common causes include thyroid surgery, radiotherapy to the head or neck area. Also, there is a new class of cancer medications that has been associated with both primary and or secondary hypothyroidism. The epidemiology of hypothyroidism is that it affects 4 to 7% of the US populations, and this occurs more commonly in women. Subclinical hypothyroidism, this is a mild thyroid failure which estimates to occur in about 13 million US adults. Study shows that there's postpartum thyroiditis that affects nearly 10% of women and often presents 8 to 20 weeks after the delivery. So let's dive into the pathophysiology of hypothyroidism at the cellular level. The most common cause of hypothyroidism is the inability of the thyroid gland to produce a sufficient amount of thyroid hormone, but less commonly pituitary and hypothalamus may also result in thyroid dysfunction. The hypothalamus, it secretes thyrotropin releasing hormone, also known as TRH. It stimulates the pituitary gland to produce thyroid stimulating hormone. Thyroid stimulating hormone stimulates the thyroid gland to produce and secrete mainly T4, which is approximately 100 to 125 nanomole daily, and small quantities of T3. Known as the half-life of T4, which is about 7 to 10 days, and eventually the T4 is converted to T3 peripherally by 5-deiodination. It says the levels of T3 majorly and T4 to some extent in turn exerts negative feedback on the production of TRH and thyroid stimulating hormones, where the alterations in the structure and functions of any of these organs or pathways can result in hypothyroidism. The decline in the production of T4 results in an increase in the secretion of thyroid stimulating hormone by the pituitary gland, which causing hypertrophy and hyperplasia of the thyroid parenchyma, and it also which leads to an increased T3 production. So let's go back to our case study with Mrs. KG, her subjective data where she was complaining of fatigue, lots of aches in her joints and muscles. She had recurrent headaches where she took ibuprofen with no improvement. She also had mild constipation, weight gain of 30 pounds in the last 6 weeks postpartum. She was also having a difficulty hearing and comprehending. And also she noted that she didn't know what was going on around her. She had a poor mental state where she couldn't care for her young 2 children anymore. And her mother was usually doing most of the child care for her. Let's look at the common symptoms. It can cause depression. There's brain fog and fatigue. The most common related symptom shows muscle cramps, cold intolerance, and there's weight gain and dry skin. In the objective data, as we see, the doctor noticed that she had a slow and deliberate speech. Her voice was hoarse. Her hands were swollen and puffy face. Extremely dry and flaky skin. She had bradycardia, heart rate of 46. According to her lab results, she had calcium that was 12.0, which is high. And we noticed there is a T4 level, which is 3, and T3 level of 80 nanogram per deciliter. She also had an elevated TSH. So let's look at the roles of the advanced practice nurse. What can we do to help these type of patients? And especially we can look into the aspects of spiritual care. First, patient assessment is crucial to enable the clinician to decide on the most appropriate blood tests and to investigate possible hypothyroidism, as some test results can be misleading. The nurses can work with providers to initiate therapy based on clinical practice guidelines and also use the research from evidence-based studies. And these guidelines are used by all clinicians to provide care, and it's very important that we stay on top of it. One of our most important roles is to educate the patient about the nature of the conditions and the importance of medication adherence, such as levothyroxine, and the need for follow-up tests to monitor their thyroid function. And we should also advocate for the patient's comprehensive care to coordinate with specialists, such as endocrinologists, physical therapists, and other healthcare professionals. We can also offer emotional and spiritual support to patients regarding their condition, and its impact on their lifestyle and concerns about caring for families. And we can do that by through offering prayers or even put in a request for pastoral care. So I want us to analyze the lab results and the symptoms. My first question is, given the patient's lab results, such as high TSH, low T4 with the presence of thyroid peroxide, antibodies, and her clinical symptoms such as fatigue, weight gain, joint and muscle pain, cold tolerance, mental sluggishness, how do these findings collectively support the diagnosis of hypothyroidism? Let's discuss the significance of each lab values and symptoms in the context of thyroid physiology. Second question relates to treatment response and monitoring. The question is, the patient showed a dramatic improvement within the 72 hours of starting levothyroxine. Discuss the mechanism of action of levothyroxine in the body and why it's important to monitor thyroid function tests after initiating therapy. What are the potential risks of over-replacement or under-replacement of thyroid hormone? Lastly, this pertains to understanding the postpartum thyroiditis versus chronic hypothyroidism. The question is, considering the patient's recent pregnancy and the onset of symptoms postpartum, how would you differentiate between postpartum thyroiditis and chronic hypothyroidism based on the clinical presentation and lab results? What further testing or follow-up would you recommend to confirm the diagnosis and manage her conditions effectively? Thank you for your time and hope you enjoyed my presentation. Thank you.